Third part of zirconia is a restorative material. This is the last part of a ceramic series in which we are going to discuss about the clinical considerations related to zirconia, factors affecting the long-term success of zirconia, what are the uses of monolithic zirconia, and what are the factors that must be kept in mind while you are selecting any ceramic material, and final conclusion of ceramic series. So very first, what are the factors that affects the long-term success of zirconia? The long-term success of zirconia depends upon five main factors. Very first, specific tooth preparation. What does it mean? For example, you are going for monolithic restorations. What is monolithic restorations? Restoration where no porcelain veneering is required. So for monolithic restoration, you will go for axial reduction of up to 0.8 mm is sufficient. And if we are going for restoration in an aesthetic zone, so in those areas more axial reduction is required. Second, material selection. How will you select this material according to functional, aesthetic requirements and occlusal forces? It will be discussed in later on. Third one is adequate cementing technique. It was discussed in part 2 and part 1 of ceramic series. Fourth one is occlusion. You have to observe the occlusion of the patient in the form of any occlusal interferences or parafunctional habits. And fifth one is skill of the dentist. Dentist must have a good communication with the dental technician. He must provide adequate tooth preparation of the required restorative material. So here we are going to discuss about the tooth preparation of zirconia restoration. For predictable and successful restoration, a good communication between the dentist and the dental technician is very important. The dentist must provide the technician with proper tooth preparation that meets aesthetic and functional requirements for the prospective restorations. The amount of tooth preparation required is highly dependent on the type of zirconia used. Now, which type of zirconia you are using for there are we have discussed in part 2 series the role of yttrium oxides. On the basis of oxides, we have classified zirconia into partially stabilized uh, zirconia and fully stabilized zirconia. In partially stabilized zirconia, if we are adding yttria up to 3%, then it will be regarded as 3y partially stabilized zirconia. 3y partially stabilized zirconia, it has high strength, it has high fracture toughness, it is indicated where high strength and toughness is required. So for 3y partially stabilized zirconia, we have to only we have to reduce occlusal surface and up to 1 mm. As a rule of thumb, 1 mm of occlusal reduction is recommended for uh, 3y partially stabilized zirconia, and for 4y partially stabilized zirconia 1.2 mm, and minimum of 1.5 mm reduction for 5y partially stabilized zirconia. 5y and 4y, they are used for better aesthetic outcome, so they required more reduction up to 1.5 mm. Axial wall reduction must be 1 mm with light chamfer margin design and taper of 6 to 10 degree. So basic occlusal reduction 1 mm for 3y partially stabilized zirconia, and for 5y partially stabilized zirconia 1.5 mm. Axial reduction 1 mm, light chamfer margin, taper 0 or 6 to 10 degree. Avoid any sharp line angles. So overall tooth reduction is 0.8 mm for interior teeth and 1.0 mm for posterior teeth. So this is the basic tooth preparation design for any zirconia on the basis of type. This is a schematic diagram for the representation of tooth preparation, and it's showing what it's showing in tooth reduction for anterior and posteriors. For anterior, we have to reduce up to 0.8 mm, and for posterior required reduction is 1.0 mm for posterior teeth. It is shown in this picture. Now monolithic zirconia. What is monolithic zirconia? Basically, it is a core of zirconia that is milled into full crown, then either glazed or polished. It has a good strength, it lacks translucency, it is not affected by any chipping. Suitable thickness of 0.7 mm, 1 mm occlusal reduction, axial reduction of 0.7 mm, 0.75 mm with well defined chamfer. These are the required tooth preparation for monolithic zirconia. Advantage is where you indicate uh, these crowns are fabricated with significantly. If you want more conservative tooth preparation, if you want limited interocclusal spaces, then you will go for monolithic zirconia. And if there are the chances of wear in opposing tooth, then you will go for monolithic zirconia because they are extremely kind to opposing tooth. Survival rate is good, not affected by any chipping. Drawbacks: they are relatively opaque. They cannot be used in maxillary anterior teeth. Now, staining and coloring of zirconia. We all know zirconia is naturally opaque. So, how will you improve its aesthetics? We can improve the aesthetic of zirconia due to its opaque nature through two techniques. One technique is known as additive technique, and second technique is known as painting technique. Now, what is the difference between additive technique and in the painting technique? In additive technique involves pre-shading zirconia ceramic to match specific tooth shade during manufacture. During manufacturing, we add certain pigments or dyes such as metal oxides to improve its aesthetic outcome. This method provides consistent color results, reduces the time and effort required for manual shading or staining. In painting technique, dental technician dip the zirconia into coloring liquids or apply external stains directly onto the zirconia with a brush. This process is also denoted as externally shading technique. With this method, dental technician have a high level of control over the final color and shading because they can adjust the amount and type of stains applied to achieve the desired aesthetic results. Now, what do you mean by zirconia reinforced lithium silicate ceramics? Advances in dental CAD and CAM restorative material have introduced this type of zirconia, and which features a glossy matrix reinforced with tetragonal zirconia fillers about 10% by weight, allowing higher strength values than lithium disilicate. This material offers enhanced translucency, flexural strength, making it suitable for aesthetic restoration. You can use for is inlay, onlay, crown, or veneers in aesthetic area due to a- addition of uh, f- uh, glassy matrix. When you add glassy matrix with tetragonal zirconia fillers, then it leads to combined properties in the form of enhanced translucency and increased flexural strength. These restoration shows a higher translucency and greater ease of intraoral polishing than feldspathic and disilicate blocks, but at the same time exhibit high brittleness. Thickness required is 1.5 to 2 mm is required for proper chromatic masking, especially on dark substrate. Now, the last topic related to this series, which is very uh, important parameters for selection of type of ceramic dental material. Which type of ceramic you will use for particular teeth, for particular indications, for particular requirements. For example, very first factor you have to keep in your mind related to selection of any ceramic material is position, either anterior or posterior. Now, anterior teeth, they require more translucent restorative material due to aesthetic requirements. So, which type of ceramic we will use in aesthetic areas, in particularly in anterior region, where a high aesthetic requirement due to high aesthetic requirements, feldspathic ceramics, but it has a drawbacks. It has lower mechanical strength. If in aesthetic areas, lack of anterior guidance or any parafunctional habits, uh, you have to note down during history taking. If you find any occlusal interferences or any parafunctional habits, then you will contraindicate the use of phosphatic ceramics. Similarly, for posterior, we go for a strong material in the form of zirconia, aluminum, bounded lithium silicate, disilicates. Design, second factor, single or splinted. For multiple splinted restoration, a strong ceramic is required. Again, strength, biomechanical risk assessment is very necessary. How will you assess biomechanical risk assessment? In the form of amount of remaining tooth structure, in the form of amount of occlusal forces. If the suspected area have a high amount of occlusal forces, then you will go for a strong ceramic material in the form of aluminum, zirconia, and bounded lithium disilicates. Now, substrate. The most important selection criteria for ceramic is based on substrate. Now, this criteria, we have to observe three important criteria. Very first, percentage of enamel, second, percentage of dentine, and third one is percentage of discoloration. The most important selection criteria for ceramic based on percentage of enamel, percentage of dentine, percentage of discoloration. Now, how? For example, a patient came to OPD. Now look at this case. Look at the 2-1, which was restored with composite restoration almost 1 year ago. It is discolored. It's class 4 restoration, which is showing 50% loss of tooth structure. So this restoration become fails. Now question arises, this patient came again to OPD with aesthetic concern. Now, which type of ceramic you will select in this case? Which type of ceramic crown you will indicate in this case? For high aesthetic demand and from mechanical standpoint of view. So here we are going to move towards lithium disilicates crown. Right? Why? In anterior we observe two things. For anterior sextant, if the presence of more than 50% enamel substrate is left without discoloration, we will go for phosphatic porcelain. And amount of enamel left less than 50% with discoloration, then we will go for lithium disilicate. So in this case we go for lithium disilicate. There are two reasons. Very first reason was discoloration. Second, enamel was less than 50%. It will be observed after removal of a defective restoration. Second, similarly in posterior sextant, we will go for which type of zirconia crown, but there are again indications. It must have a height 3 mm, less than 3 mm, and convergence angle greater than 20 degree. If we summarize the basic indications of all ceramic materials, in conclusion, to conclude, we can say that in posterior region, for a strong material in the construction of crown or bridges, monolithic zirconia is preferred, but the gold standard will always be metal ceramic crown. Second, in posterior region, in a patient without any parafunctional habits, you will go for monolithic lithium disilicate. It may perform well in the premolar region, not in molar region. In anterior region, for a single crown where high aesthetic results are expected, lithium disilicate is preferred material. In anterior region, for a bridge and satisfactory aesthetic outcome is indicated, layered zirconia can be chosen. Means its basic core will be constructed with zirconia, and that will be it's coated with phosphatic ceramics, layered zirconia. In anterior region, for a discolored tooth or tooth restored with metal post, you will go for layered zirconia. So this was the last part of the modern dental ceramic series that was covered in with more detail in this part. So with this we came to the end of the ceramic series. Review of modern dental ceramic series ends here. This was the last part.